disease doctor, is both clinical and research focus is in HIV and specifically PrEP. So he's going to talk about a little bit more about his work on that today. And then if you have time for questions, you can ask him clinical questions about his training. I think you're the first.
Yeah, are you guys all from Durham and shit like this area?
No, we have a diverse crew here.
You talk about Durham?
Yeah.
Whatever. The other thing we can't talk about is stats, as Richard knows, like maybe mode. I know what standard deviation is. I don't work on calculating one, but
Yeah, I think we had Dr. Bartlett join us over Zoom, but I think you're our first MD, right, to come in person. Right? So they might have questions.
Cool. So this is really informal, just like yell me to stop or if you have questions. But I'm Charlie. I'm originally from the Chicago area, but then I was at Wisconsin for a little bit, then Cleveland, and then down here. So if you guys are from any of those areas, then we can talk about that. But I want to talk about PrEP, so HIV pre-exposure prophylaxis. You guys all heard about HIV pre-exposure prophylaxis? What do you guys know about it?
We've learned a lot.
So one of the things that always surprises me before I give these talks is that, I was in medical school in 2010. 2010 is when I started. And so these drugs came out in 2012, and I didn't hear about them at all. And I'm an infectious disease doctor and somebody who's interested in HIV and HIV prevention. So the first time I ever learned about these drugs was like 2017, 2018, right? And so the sad part is that these drugs have been out for 10 years, but like most people don't know about them, which is unfortunate. There's a lot of reasons behind that, which we can talk about. But anywho, so if you've heard from like Amy Corneli and those guys, you've heard from like real implementation scientists. So I pretend to be one, and we'll talk about this a little bit. The only disclosure I have is one of these studies. We'll talk about a partnership we did with Walmart. Walmart doesn't pay me any money, but just in case you guys care. But we're talking about HIV and PrEP and pharmacies, and then PrEP kind of in urgent care, which is what I've been working on. So the ongoing HIV epidemic in the United States is still a big deal. One of the kind of sad things is that if you're looking at welcome. So if you look into politics, right? So politics made this ending the HIV epidemic initiative, and if you talk to any politician, right, they all think the goal of the ending the HIV epidemic is that HIV is going to be gone by 2030. Without me telling you anything else, I believe you all probably believe that's not going to be the case. But politicians do, and so they think that we're going to be done in 2030 and that there's no more work to be done. So remember that when you guys are voting. But this data is from 2021, and so the data is always a couple of years behind the actual years it takes to compile it. But in 2021, there was over 36,000 new HIV diagnoses in the United States. Most of them were among gay, bisexual, and other men who reported men have sex with men. 22% were among heterosexual contacts, and then 7% were persons who inject drugs. But again, there are disparities in HIV diagnosis. So you can see even among all these groups, gay and bisexual men, heterosexual women, heterosexual men, and persons who inject drugs, you can see the HIV epidemic is disproportionately affected by Black and African Americans and Hispanic and Latino persons as compared to, say, white or other individuals. Again, talk about that. That's outside the scope of what we're talking about right now. There's also disparities in where HIV diagnoses are being made. So again, the South is only about, I guess in this one it's 38, but in more recent, it's a little less, 36% of the U.S. population. But we represent over half of new HIV diagnoses in the country. North Carolina in particular is rated the 6th highest state for new HIV diagnoses. And you might go, 6, well, that's pretty bad, but not so much. Well, when you compare it to the states that are above it, those are states like Florida, Texas, New York, California, Illinois, I'm blanking on one, but maybe Texas. But it's areas with much higher population, much higher like urban populations as well. So when you think of it per capita, we're pretty far up there. And then you can see with my little mousey here, if you squint really hard, this is generally our area kind of right here, so the darker is the worse. So we're kind of in the thick of it here too. And so to combat HIV, UNA, the United Nations AIDS Prevention Work Group, has made the 90-90-90 goals. And so the idea is that we're going to have 90% of persons living with HIV aware of the status, of them 90% on antiretrovirals, and of them 90% virally suppressed. But as you can see, we're not there. And the goal of this is actually to be by 2025. We're nowhere near there. So there's still a lot of work to be done. And this is global. I can tell you that the United States is not much better. In North Carolina, we're doing pretty good at the first one, which is the diagnosing of people with HIV, but not the rest, not the getting them linked to care and then remaining on care, which is another project I do, which we kind of interested we talk about that later. But yeah.
How do you know the denominator for the people who are living with their status but don't know it?
It's based off of CDC estimates. So they do some sort of fancy math about what they expect the prevalence to be, and then go from there. So on the HIV epidemic, the government has released the Ending the HIV Epidemic Initiative, and their overall goal is to decrease the number of new HIV diagnoses to 9,588 by 2025. So that's a reduction in 21,000 in the next year, which is not going to happen, and then 3,000 by 2030. And we're not going to get there. And to do that, they highlighted these key jurisdictions for novel HIV prevention, novel HIV intervention projects. And these are called there's 7 key states. And those key states are highlighted based off of specifically disproportionate HIV diagnoses, especially in rural regions. People always ask, well, why is North Carolina not one of them if we're number 6? I couldn't tell you. I don't really know how these states were chosen, but these are the ones. And then outside of that, there is I believe it's 57 counties, which are priority jurisdictions as well for novel interventions. Those are all the things in dark blue. So North Carolina is only Mecklenburg County, which is where Charlotte is. But if you actually look at the per capita rates of HIV in Charlotte and compare it to Wake and Durham County, we're right up there too. I think we just didn't get selected because they just physically have more people than we do. But again, I don't know the politics of exactly why all these places are located. But if you guys are going into research, right, this is something to know because most of the time when there's grants that come out, the government wants you to target these areas or justify why you're not. So for instance, I do a lot of stuff down in Tallahassee, Florida, which is, if you guys don't know, it's generally right around here. It's not an EHE site, but you can make the argument of the rates of HIV and STIs in this area are very similar to all these other ones. And the EHE, we're going to keep calling it EHE. They highlight 4 key pillars to combat HIV. So the first one is diagnose all people with HIV as early as possible, treat people with HIV to reach viral suppression. Did anyone talk to you guys yet about U equals U or TSP? Okay, so that's what that's all about. Prevent HIV transmissions using PrEP and syringe services programs and respond quickly to HIV outbreaks. So again, a few years ago, there was that big outbreak in Indiana, for instance, and making sure people get the response to that. So we're going to focus on prevention for the rest of this talk here. And so remember we were talking about PrEP, just as a quick refresher, PrEP's been out since 2012, or 2012. There are 3 different PrEP options right now. 2 of them are pills, that's Truvada and Descovy, and then one of them is an injection, which is Apric. But you can see that it's underutilized. So again, these are government estimates of persons eligible for PrEP, and this is based off of STI and other prevalences that we know about. But they estimate there's 1.2 million people who could benefit from PrEP, but only 36% are actually getting it. Now, if you're an optimist, you say, well, that's better than 23. But again, it's very underutilized. And you may ask, well, is this an access or a cost issue? And the answer is maybe. But for persons without insurance, there's the Ready Set PrEP program, which gets you free medications. There's a K-Mister, which is free. And at least here in Durham, right, you can do to get on charity care, you get it for free too, which I imagine interaction exists in other areas. But there's also disparities in PrEP use. So remember we said persons who are Black and African American or Hispanic or Latino are overrepresented in HIV diagnoses. Well, here they are also underrepresented in PrEP use. So the majority of PrEP users are white. It's also, again, the same thing, the regional disparities in PrEP use. So again, we said the South is the area of highest HIV diagnosis in the country. Well, it is also the area of lowest PrEP use compared to any other region of the United States or the national average as a whole. So they do this based off the PrEP to need ratio, which is the number of persons using PrEP divided by the number of new HIV diagnoses in the country. So, or in that region. So again, higher number is better. And we can, again, questions to get into, all these little things our own talks into themselves, but we can, if you have questions, let me know. But how we get there, so again, there's a lot of interest in this. So, there's nearly 600 million going to EEG initiatives. Here's the breakdown there. So 220 million to CDC, 332 million to health services. So that's like, again, more or less like the 3 government-sponsored covered care. 50 million to Indian health services and 26 million for research projects. And there is talk about expanding the EEG jurisdictions, but I don't know. I don't know if that's going to happen or what the status is with that. So again, focusing on the third pillar of prevention, and for us, we're really going to talk about PrEP some more. And so there are a lot of PrEP barriers. This is very simplified, but you can think about, cost of PrEP, stigma. So again, in the South, right, I have patients who will drive 5 hours to see me because they don't want anybody in their neighborhood to know that they're on PrEP. Provider awareness. So unfortunately, a lot of providers do not know about PrEP. And some of them that do will refuse to prescribe it for various reasons. User awareness. So again, a big issue, for instance, we did a project trying to look at women to use PrEP. And a lot of women say, oh, no, PrEP's not right for me. It's not, I'm not eligible for PrEP. And a big part of that is if you look, you guys watch TV and see ads for PrEP, right? What are the ads always? Gay men, right? It's always gay men. It's never women, it's never anything else. And so a lot of women look at that and go, I'm not a gay man, I don't need that. And then the focus we're talking about here is access to PrEP. So in the South, you typically get PrEP at big academic centers, and that's usually it. Not all health departments have it just because they don't have funding, and not a lot of primary care offices do it. Some do, but again, some don't, again, because it's stigma, they won't ask for it, or there are, viewpoints on these things which I don't agree with, but some physicians have and won't prescribe it. And so, so for persons who are maybe in the rural South and who are eligible for PrEP, they may not have means or the ability to come drive 3 hours to Durham and see us here at Duke. And so, one of the thoughts we had with that is, can we make PrEP more accessible to these individuals? And so one of the locations we're looking at are pharmacies. And the reason for that is, pharmacies are really accessible, right? Like, they're usually the first line a lot of contact people have with the healthcare system, right? If you live in the rural South, you may not be able to see your doctor, but you can walk in and talk to pharmacists, right? And say, hey, I want my blood pressure checked, I want vaccines, or, what should I have a cold, which medicine do I use? There's been studies that show that people view pharmacies as a less stigmatizing location to get HIV testing. And again, they are pretty ubiquitous. So 90% of people who live in urban populations live within 2 miles of a pharmacy, and 70% of rural persons live within 15 miles of a pharmacy. And pharmacists are doing similar stuff already. They do preventative health screening, they do vaccinations, Plan B, needle exchanges, Narcan, other therapeutics. So again, there's a big highlight with this too, after the COVID epidemic, right? Because pharmacists really stepped up and played a role in vaccination, kind of public health. And just to kind of highlight this, I'm not going to read this, but the White House has their national HIV/AIDS strategy from 2022 to 2025, and they even have a whole section where they're highlighting pharmacists' role in HIV prevention and care. And I don't know why this part's highlighted, but the point is that there's a lot of support and a lot of agreements that pharmacists should be playing a role in all this. But there's a lot of pitfalls for pharmacists. So again, if you're working at Walgreens, you probably don't have a lot of time to talk to people because you're filling, 400, 500 prescriptions every hour. What's the cost, right? What's the cost of a pharmacist's time to do this? What's the cost of the medications? Who's paying for the lab work? and then a lot of red tape. So, our pharmacists even allow us to do this, which is good. My next slide. Good thing. So as of last time I looked, there are only 7 states where pharmacists can prescribe. So similar to North Carolina, right? If you wanted Plan B, you walk right in and say, hey, pharmacist, I need Plan B, and they go, here you go, have a nice day, right? In these states, you can walk in and say, hey, I want to get on the HIV prevention medicine, and they can go, here you go, have a nice day. But unfortunately, none of them are in the South. They're typically in more progressive states, as you can see. And realistically, and again, this is a heat map of kind of where HIV is more prevalent. And realistically, right, our goal is not to get these laws changed, because I think that we're probably not going to get there anytime soon. So the question is, how do we circumnavigate this if we can't have pharmacists prescribing PrEP here in the South? And so there are other ways pharmacists can get involved. Pharmacists can make sure that persons are aware of PrEP. They can do PrEP consultations and talk about why PrEP is right for you, or why you might want to think about PrEP. They can refer you out to somebody who can prescribe PrEP. They can help with cost assistance. They do this already for a lot of other drugs in terms of assistance programs. They can make PrEP more accessible. They highlight it or advertise it in your pharmacy. And they can help with medication monitoring, just to make sure you're tolerating it and you're taking it appropriately. And again, they're already providing similar care. So again, a lot of those pharmacists are providing needle exchange services. They're doing routine health screenings. They're providing vaccinations. So, the question would be like, if somebody comes in for the HPV vaccine, you can say, okay, well, it looks like you're interested in preventing a potentially sexually transmitted virus. Have you thought about HIV, right? Just kind of rolls in there in the same clinic visit. And so the first thing we said is like, all right, well, if you want pharmacists to get involved in this, we need to make sure that pharmacists are aware of PrEP and have a working knowledge as to how it works. And so we did this partnership between, it was Duke, some people who are adult learning area experts who make like online modules, Walmart for pharmacies, and then the Elton John Foundation is making a national curriculum for pharmacy staff at Walmart. And so this is what we developed and rolled out. The idea was, these modules were not mandatory, although they were highly encouraged by the CEO, so I don't know if that's considered mandatory, but nobody had to take it. You got continuing education credits, and they were made in 10 to 15 minute modules that you take in short periods of time. They come back at any time. And so we made a core module, which is ideally for people who didn't know anything about PrEP. And what it kind of boiled down to was, again, understanding your role in the HIV epidemic. So looking at the epidemic in the United States, understanding how pharmacies can play a role and are important, and then how to have these conversations with compassionate care, providing quality care. So again, looking at the barriers to HIV, current options, or for various HIV prevention, current options for PrEP, and then communication strategies for how to bring up this clinic setting. And again, next one was again barriers to PrEP. So again, how to help patients overcome these barriers. How to talk about PrEP. This is really about using inclusive language. How to access and other patients knowledge about PrEP, and how to be prepared to answer simple questions. And then an overview of stigma that persons with HIV and persons seeking PrEP may face, and why that may impact them seeking care, and kind of how to make a comforting, welcoming place for them. And then after that, we had advanced modules, and same story. Nobody was required to do these, but and you could take these instead of the core modules. But this kind of delves back in. So again, looking at HIV incidence and priority population. So again, kind of helping pharmacists understand who their patient population is and why, and who within their target population may be eligible for PrEP, or who they should be talking to. Clinical prompts for PrEP. So again, for pharmacists, if you're going to have these conversations, how do you recognize who may benefit from PrEP care? So things like, if you're clearly filling a prescription for STI, sexually transmitted infection treatment, right? If somebody comes in and is asking about certain vaccines, like we're talking about the HPV vaccine, if people are just coming in for general wellness checks, just making, mention that this is available, or if people are buying things like condoms, STI, or condoms, pregnancy tests, Plan B, just kind of bring it up PrEP at the same time as that. And then more of the nitty gritty here is like, management of PrEP, so you can have that conversation with patients, how to pay for PrEP, in terms of like those support programs, and then other HIV risk reduction methods. So somebody says PrEP isn't right for me, which is find like what else can you be doing. And so the way that this looked on like the pharmacist side of things was, I can't show you because Walmart owns it now, but it's usually there's like a pre and post test, and each one has a verbalized, animated talk kind of going through those points to educate it, and then each one actually has like a animated like person walks into the pharmacy and the pharmacist talks to them, and it's usually like they did it bad, and then it goes through like why was that not the appropriate way of doing this? How can you do this better? And that's kind of what each one look like. In terms of distribution, we did a staggered distribution to allow troubleshooting to roll out, right? Because we're going to do this nationally, there were problems were going to come up. And so 2 modules went to 80 associates on World AIDS Day in 2022, and then we expanded that out shortly thereafter, went nationwide in February. The remaining modules all were released in March, and then the advanced modules were released April of last year. They were kind of hosted by Duke here. It was sent throughout all of Walmart. And for the purposes of this, we arbitrarily chose August 23rd. I think it was 6 months from something. There's some reason we chose that, but maybe 6 months from going nationwide. That's why we chose that date to kind of say, hey, here's where we're at. I will tell you this is still live, and so all these numbers are going to look actually better than what I'm showing you. But just for this snapshot. And so as of August of last year, you can see the core modules versus the advanced modules. There's a nice mix of different training services. I cannot tell you what a fellow is or a counselor or a consumer is because Walmart won't tell us, but that's how they list their employees and their demographics of things. But the cool thing here is this is people accessing the core modules. I think the cool thing here is that the majority of people accessing the core modules are actually people in the South. I don't know why that is, unless pharmacists in the South are vaguely aware that the HIV epidemic is kind of raging in this area. But I thought that's pretty cool. But I don't really know why. I don't know why Florida, for instance, is the most. For those of you wondering, North Dakota has 0 because they don't believe in HIV there. Not that true. There are no Walmart pharmacies in North Dakota. So, fun fact: in North Dakota. I looked this up because I was curious. If you have a pharmacy, it has to be owned and managed by a pharmacist. And so because of that, there's not a lot of chain pharmacies up there. Interesting country we live in, different laws.
What's the motivation for them to do modules?
Nothing. They get a letter from the CEO saying, hey, you should take these modules. I mean, the thing that they get out of this is that, when you're a physician or a pharmacist, you have to do so many continuing education credits. So they get continuing education credits. Why they did this? I don't know. But yeah, there's no incentive. There's no money or other. The only invite was, my understanding, was the CEO or the CMO sent an email that said, hey, we're partnering with Elton John. We want to increase HIV awareness prep in our clinics. Here's some modules made by Duke. Okay.
The number is the number of people who took it?
What?
The number is the number of people who took it in the state?
Mm-hmm. Yeah. So this is the advanced module. So again, these numbers are a lot lower if you look at the timing that we were just saying, like these have only been out for a few months before you pause to look at the numbers. But again, the same thing holds true is that the South has the most people taking it compared to everywhere else. And I don't know why.
Can you account for, because I don't know how many, the amount of Walmart pharmacies in these, because I'm assuming that varies a lot by state.
Yeah, so I don't know. I don't know if there are more Walmart pharmacies in those states. I would imagine each state is a little bit different, but I don't imagine that Florida's that much different. Like New York with all the pharmacies in New York or Chicago, right? But
yeah, there may be more Walmart pharmacies in Florida.
Yeah,
not to that amount.
Right. Yeah, I don't know. We did learn that working with Walmart is kind of difficult because they don't like to tell us things. So we asked. So we did ask that. Skirted the subject. Okay. And so what we did is we looked at comfort and stigma change before and after taking this study. And so I personally don't like how some of these questions are worded, but this is based off validated HIV/AIDS stigma scale. And so the idea of this effect size is that the way you can think of it is the bigger the number, the more effect size it was, and the smaller number was less. And so it really changed or helped people feel more confident about PrEP and PrEP education, PrEP counseling. It didn't make much of a difference in working with persons who are in the LGBTQ community, but some of the feedback we got from pharmacists was that a lot of these pharmacists were already comfortable with those populations, therefore we didn't really move the needle much, right? So if everybody said, I'm confident, and then they said, at the end of this, I'm still confident, there's not much change.
Did everyone who did do the module answer the question?
No.
Do you know how?
I do, that's a good question, I don't.
Okay.
We did ask, I don't have it on here, but we did ask people for more like qualitative feedback, right? I didn't post it on here because I didn't find it very helpful. So it was either a realm of this was great, or I'm going to spout some sort of political thing that I didn't think was worth publishing for anybody. Yeah, so the next step of this side of things is that we're trying to look. At least a big outcome was that we now have a partnership with the Elton John Foundation, which we're working with them a little bit further on. Walmart has kind of said that's enough for us. We're hoping that they come back and work with us some more. But the big change for Walmart is that now within their medical record or whatever you want to call it, they are now updating that so that they ask all their customers to prefer pronouns and names. So that if you get your script from Walmart, you should say, if you want to know if I prefer names, so just it's worth maybe asking. But the way we're trying to look at this now is more formal, like, hey, what do pharmacists think through in-depth interviews? What's the uptake? How many pharmacists are actually doing this now? And then, the pie in the sky thing would be looking at like, hey, is there a change in prescriptions? I don't know how we'd ever manage that because it'd be too hard to see how many of these are coming from pharmacists versus not, but it would be cool to do. But yeah, so then moving on from that, so we said, all right, so we have the education in place, the pharmacists are learning about it. So how do we actually get this into practice and get pharmacists to actually do it? And so we decided to partner with community-based pharmacies, and the reason we chose community-based pharmacies is they're all independent pharmacies rather than like Walmart is, one, less administrative barriers. Frankly, it's just easier. So a lot of the leadership already has buy-in for this. They're already engaged in community health measures. They have close connections. A lot of them know their clients by name and have close connections with their local clinics. So, for instance, when I went to one of our pharmacy partners and I was like, hey, just off the top of your head, do you know anybody who might benefit? I was like, oh, yeah, Bob comes in here once a month and gets his needles for diabetes, or, we got no diabetes. You're like, right? Or they know all of their local doctors who they can talk to. And then again, potentially they have more time to do consultations and again, can identify patients who may benefit from PrEP. And again, we already kind of mentioned this, but these were the potential pharmacy indications for PrEP discussion that we kind of brought up at a community pharmacist setting, which is not exhaustive. And so because of this, we formed partnerships with different sites. So we have Charlotte, North Carolina. Remember, Charlotte is one of the EHE locations. We're working with the Premier Pharmacy and Wellness Center. And again, we have clinical partners as well who will help prescribe PrEP. Columbia, South Carolina. So Columbia is interesting. So Charlotte's a pretty urban population there. Columbia actually is 3 different pharmacy sites, and they're all kind of surrounding pharmacies, just Columbia going down to the rural setting. And so I think it's a little different because, talking to pharmacists in Charlotte, their target population is going to be mostly men who have sex with men or STIs or sexual transmission. Columbia is actually more IV drug use in that region. And then we're also partnering with Tallahassee, Florida. So Tallahassee is not an EHE state, but it's similar. And we're working with Florida A&M pharmacies. So again, we're going to be on the campus of historically Black College University and working with pharmacists there. And what we're doing to unlock them to provide PrEP care is what's called status neutral HIV prevention care. So this is described by, again, the CDC, and it's kind of, the point is you meet all your patients regardless of what their HIV status is. If they're living with HIV, you go to the treatment pathway and you're making sure they're getting quality care, you make sure they're meeting their primary care initiatives, and then they're staying on their effective treatment. And if somebody without HIV, then you're making sure that, again, they're getting HIV testing, STI testing, they're having conversations about HIV prevention as well. And so with that, the pharmacist would talk anybody who's coming in the door, they wouldn't necessarily say like, hey, the HIV thing before we talk about it. So again, the scope of our project is the prevention pathway in the pharmacy setting. And what we're trying to do is vaguely this. So the goal of our project, at least right now, kind of a preliminary stage, is not trying to see what the uptake or the efficacy is in terms of the PrEP prescriptions, but just more of the feasibility and acceptability of whether or not a community-based pharmacy referral system works. And so the way that it's looking is that, across the whole study period, these pharmacists will have HIV tests available through the health department. At the initial setting, right, they'll have advertisements for PrEP education pamphlets. So again, the pharmacies identify something you might want to talk about PrEP. You have a pamphlet that says here's what PrEP is, and then for each individual site, it'll say, local clinics that will prescribe PrEP or possibly further out. We'll roll that out for a little bit, and then after that, we will do personalized PrEP counseling. And so before this, me and some other PrEP doctors up here will go down and talk about what PrEP is, give education. But personalized PrEP counseling, so instead of a pamphlet, is the pharmacist saying, hey, here's why PrEP might be right for you. Have you thought about it? Can I answer questions? And then after that, a little bit, we would roll out real-time PrEP clinic referrals. So after they have that conversation, instead of saying, here's your pamphlet, go to one of those places that do PrEP, you say, hey, I'm gonna call the clinic for you while you're in the room with me, and I'm gonna make sure when we walk out the door, you have a card that says, hey, I'm gonna see you tomorrow for PrEP. And what we're trying to get out of this is, again, not how many people get PrEP prescriptions, but again, how many times the pharmacist offer PrEP screening? Was it well received? Was it not well received? Why they offer PrEP screening? It's kind of again the preliminary work to kind of expand this out a little bit later. And so, the first thing we're going to do, ignore this big busy slide, but the first thing we're going to do is, that we've done, is in-depth interviews with pharmacy clientele, so pharmacists, pharmacy techs, pharmacy administrators, looking at the Bowen outcomes of feasibility, acceptability, demand, practicality, integration. So again, before we do this, just saying like, hey, this makes sense, how should this look? Is this something your clients can use? And try to figure out what kind of barriers and facilitators we're facing before we roll this out. And then after that, we're going to run based and kind of adjust it based off this. And the things we're going to look at after we roll it out is again, adoption. So how many pharmacists are actually providing PrEP counseling or PrEP referrals? How many participants, like how many patients who walk into the pharmacy are accepting these interventions? Then again, how these outcomes? How many people did we reach? Did they look like the typical clientele in that area? Or was it only young people wanted it versus old people? And again, and then future studies are going to look at again the effectiveness, and then how many people are actually getting PrEP prescriptions and how well is it sustainable over time. And through this, again, we're building new partnerships between Duke Infectious Disease, Duke Pharmacists, community pharmacies, and the Duke CFAR to kind of build this out and make new interventions later. And so this is where we're at. We can move the deal a little bit. We're done with the interviews. They're analyzed about the focus groups, and then our plan is to do focus groups kind of come again this month, and then go down there in August, do some education, and then kind of launch our intervention for the next 9 months. So again, kind of the preliminary thoughts is that everybody's willing to do PrEP counseling. They think obviously the passive model is the easiest, but again, there's kind of the usual concerns about time privacy, how we tell somebody they have HIV, and then how are we actually make these referrals. I didn't put this on here because I forgot. I had given this talk previously to another group that's seen my work, but before all this, we had actually surveyed pharmacists all throughout South Carolina, as well as did interviews to kind of get the preliminary feasibility, acceptability. Generally, that was okay. So moving on then, switching gears here a little bit to the urgent care setting. So a very similar idea, but a different location. And so the reason why we were thought about urgent cares over, the traditional healthcare settings is, again, urgent cares are community facing, they're more ubiquitous, right? Like, probably closer to urgent care doctor than you do to And for many people, it may be the only access point to care that they have. There's been consumer research showing that young people generally prefer urgent cares over a more traditional physician setting. And that's important because, again, young people are one of the highest groups of new HIV diagnosis in the country as well. And then through our work and our preliminary work with urgent care docs, most of these urgent cares are seeing multiple sexually transmitted infection visits a day. They're not necessarily talk about for various reasons. And so before we kind of started this, we did a survey of urgent care clinicians across the South. We did this through the American Academy of Urgent Care Medicine and the Urgent Care Association, and looked at publicly listed listservs. And the response rate was, pretty low, but it's actually was on par with response rates to other surveys for medical people. We've got a good kind of mix of demographics and practice ranges. And the key point of this, you don't have to read all of it, but the key point of it is that most people thought that providing PrEP would be beneficial, and that it would be that they should be doing, like, talk about PrEP would be beneficial. But there's mixed opinions about, like, how common HIV was in the community. So again, all these participants were from the South, and so they thought, it's not that common, but again, realistically, the South is where most new diagnoses are occurring. And there was mixed opinions about whether or not the urgent care was the right place to provide PrEP. Skipping ahead a little bit, we did interviews, and the reason why they thought that they weren't sure about if it was the right place is just they don't want to follow PrEP long term, so they don't want to do like the PrEP doc following people over months and months and years. But they thought it would make more sense to be an entry point to PrEP or like a safety net for PrEP. So then we dug deeper again with in-depth interviews. We did 12 urgent care clinicians from the Raleigh-Durham area and 12 current and forward PrEP users. And that's the cool thing was that we got a good mix of people from this area who thought they were living in rural areas as well. Again, same thing as we were talking about before, just kind of look at the feasibility, acceptability, appropriateness of this type of model. I'll look at that one. But anyway, I think it's much more. But so the gist of it without
Could you go back to the two so you said there was a good mix. It seems that for PrEP user, it's only assuming men, and there doesn't seem to be community users.
So that's reflective of PrEP use overall. There's very little women in PrEP, and very few women in the Duke PrEP clinic as well. So we couldn't get anybody. That's unfortunately a big problem with the PrEP field as a whole. So, of the 3 medications, right, Truvada is used for women, but Descovy cannot. And the reason for that is not because Descovy, it probably works just fine, but the reason that is a big issue with PrEP is getting women to use PrEP. And so for those studies for Descovy, they just couldn't get enough women to sign up for trials so they can get the indication for it. So that's you're right. So that was all men from the current and forward PrEP users, but the lack of women is kind of a systematic thing overall with PrEP too.
Is that just in the States or overall?
Like over the country or over the world, you mean?
Yeah, over.
So another issue is we don't actually really know. There's not a lot of data coming out of anywhere else other than the United States, Canada, and then a couple of European countries. And so we don't really know. The big studies from the clinical trials of PrEP included women, and those were in a lot of different African countries, but that's a whole different thing, right? Because those are clinical trials, so you have people who are like following people up and trying to find them, right? But there's not a lot of real world data on PrEP use. There is in the United States, and throughout the United States, it's the same thing. It's very low women using PrEP. We can talk later. We did a project trying to go around Durham, trying to talk to the Durham Housing Authorities, trying to talk to women about PrEP. And again, it went very poorly because every woman we spoke to was like, not for me, I don't need PrEP.
Okay.
And that's, again, it's a whole other topic, but yeah. So I think we're here. So without getting too in details of the interviews, the gist of it was that PrEP users didn't really care where they got their PrEP from as long as it was convenient So they did like a long-term relationship with their prep provider if they had one. And they said, like, yeah, urgent cares are good because we go there a lot of times for STI care. Urgent care clinicians, they, similarly said, yeah, we see a lot of STI visits, so we probably should be talking about PrEP. I'm surprised that we don't. They think PrEP is beneficial, and a lot would agree that, hey, we should have better role in preventative care because, again, we may be the only physicians that somebody sees ever. And so their shared goals were that, again, maybe urgent care should be a point of entry or safety net for PrEP. And again, highlighting the importance of like they may be the only location for care within the healthcare setting. And so again, the kind of future directions for this, how we're getting persons who may benefit from PrEP into urgent cares. And so one of the things we're working on here is to do peer recruitment. So again, in a study that we did of our PrEP, people on PrEP in our clinic, people who are either self-referred or referred from their friends actually stayed in PrEP care longer than persons who were referred from like a community-based organization or a doctor. And we think that we need to be aware of, what's been shown is that if you have self-awareness of your HIV risk, you think PrEP is beneficial for you, you're more likely to stay on it than if somebody's like, hey, you should be on it. And so our thought stemming from that is that, hey, if you're on PrEP and you know somebody who else who should also be on PrEP, if you hear from like your buddy who says, hey, you want to go down the urgent care and talk about this medicine, I think it's easy, right? Is that going to be a way to kind of reach some of these marginalized communities who may not be aware of it or willing to talk about it other ways? And then again, doing like a social network analysis, kind of like the 6 degrees of Kevin Bacon. So again, if you know one person on PrEP, do they know one other person, 6 other people, and then did that person know one other person? So again, if you had this rolling out in the community, like how far is your potential reach to get to where you may benefit from PrEP use, especially among like women. So putting it all together, doing these new access points with PrEP leads to increased PrEP access. If you increase PrEP access, you'll increase PrEP to need ratio and then hopefully decrease HIV transmission. And that's again reaching towards the overall goals. Remember, the 75% reduction in new HIV diagnosis by 2025. We're not going to get there. A 90% reduction by 2030. We're very much not going to get there either. These are all the people we work with. That's all I got. So we got 15 minutes early, but I'm happy to answer questions or comments or talk about other things I'm involved in. Or do you guys have a breakdown? You guys plan is, but
Yeah. I'm sure that'll be.
yeah.
You mentioned that there were various reasons why the providers don't prescribe PrEP. What are some of the reasons?
Some of it is lack of awareness, right? They don't know, for some reason, a lot of physicians are very scared of antiretrovirals. I don't know why. I think it all stems back from like the earlier 90s when like all the medications were very toxic and hard to manage, but now they're all very well tolerated. But I think that kind of viewpoint still exists. Some people don't know. So some people don't know it exists. Some people don't really know how to manage it. Some people go like, well, it's not beneficial, which is maybe wrong. And then there's some people who just are, unfortunately, say, I'm not going to do this because I don't own that lifestyle. And a lot of it too is kind of echoing like when birth control came out for women in like the 60s, right? Where doctors would say, hey, we're not going to give up birth control because then people are going to go, people say, hey, if I give up PrEP, people are going to go run around and not just kind of like gonorrhea and syphilis are going to go on, right? And they're going to be like, well, keep those. But so this is a whole 2-hour we're talking about that. And then there's also the thing with poor patients, right? So if you live in a small rural town, right, and you go talk to your doctor about PrEP, and then you pick up the pharmacy, and the pharmacist goes, oh, Billy just got PrEP, so you know what that means, right? Then it gets around to the town. So again, I have patients who drive 5 hours to come see me. They will come and see me, pick up their PrEP medicines from Duke, and then that's that, right? So there's a lot of issues there. Yeah.
So you said the only use that you're getting on PrEP is still in the United States. So I think future possibilities of integrating the PrEP into like the South Africa from the 25%.
So they have PrEP in all those areas. Yeah, it's PrEP this. I don't know the politics about every particular country, but it does exist like South Africa, Sub-Saharan Africa. There's other issues there in terms of access, cost, all that. stop using it after 6 months. And there's a lot of reasons for that too, but we don't know, right? Is it people who are just like, like think about like taking a daily vitamin. You take your daily vitamin every day, or is it people who are having what we call like seasons of prep use, meaning like, hey, I'm single, I'm going out to the clubs, I'm gonna be on prep, now I'm in a committed relationship, I don't need prep anymore, we broke up and now I'm again. So we don't really know. And that's another big issue of like how effective is it if people aren't using it. And that's what I was referring to is prep is more or less everywhere. Again, I don't know the politics of every country, but we don't have data showing like, hey, yeah, in the United States, only 30% of people are using it, whereas in South Africa, 90% are. Then what are we doing wrong, right? So we don't.
Sorry.
Yeah.
So you said that the way you were gathering the data reflects the current situation where a lot of women aren't really ready to take. Do you guys have any projects for trying to get women to be more?
Yeah, so we talked about that band project, where we had focus groups of women to figure out about prep, how to make prep increase prep awareness among women persons. So that's an ongoing project. And then for all these projects that we're doing, right, we're highlighting it. We should talk a little bit about it. But again, the big problem for women, at least from a lot of studies and what we've heard is again marketing of it. So women don't feel like that they need prep because when they see the advertising, they see gay men, they go, well, I'm not a gay man, so I don't need prep. Right? And unfortunately for a lot of women, when you talk about like the quote unquote risk factors of here's the people who should be on prep, they go like, I don't do any of those things, right? But a lot of times women, their risk is tied to their sexual partners. They not be knowing what that person is or is not doing. And unfortunately for some women in the States, it's concerned too, because there's domestic violence, and then partners find prep models. They go, what are you doing? Why are you on this medicine? So there's a lot of reasons. And there's a lot of projects out there working on it. Me in particular, it's mostly that band project. And that if you like look at like NIH and say what's fun for women on prep, there's a lot of stuff going on. Yeah.
About the courses, the core and the advanced. Is there a part where we talk about this of taking prep or around it?
Yeah, so there really aren't. Prep is well tolerated. I mean, but yes, we talk about like the side effects, right? So for the oral pills, right, the biggest side effect is that a lot of people have startup syndrome where they might have some diarrhea or some GI upset for a week, but then you push through that and it goes away. For Truvada, you have to have good kidney function. It doesn't really affect you, so you can have bone demineralization over time. So it's maybe not something that you want to do if you're like an older woman who's at risk for osteoporosis, but all that's reversed. Descovy, again, you can use that with a lower kidney function, but may or may not change the lipid, check your cholesterol. But again, these are medicines that people with HIV are on for. I don't know, decades, I don't know if they're on for that long. But years, they're the first line drugs people live with without real side effects. For Apretude, the biggest side effect is that big old injection in your butt. So again, that's these medicines. There's a lot of people have fears about them. They're well tolerated. They've been out for a long time. They don't have a lot of side effects. You're more risk taking your Tylenol than you are. Yeah.
I'm curious because I didn't have it about prep until I started the internship, and you were saying that you heard about So do you think would make those changes, or why do you think it's so bad? Because I talk to my family or friends, and like, oh, this is so cool, and they haven't heard about it either. So okay.
Like I don't, so there's within application science, there's a study which I can blank on what it is right now, but it's like 17 years from when data shows that something is effective to actually putting in full practice. So it's something like that, maybe. That's the big thing about application sciences as a field is the question of, we have prep. Prep is over 99% effective at using HIV, or preventing HIV. Nobody uses it. Why, right? That's what people are trying to figure out. So I think it's a little bit of it's just new, and it takes a long time for new things to get out there. I think the other thing is maybe kind of society climate, right? Like when it came out in 2012, when somebody put a commercial on TV of two gay men going, I'm on PrEP. I don't know, right? But now that seems to be more, more easily marketable or whatnot. So I think it's kind of a mix of just awareness in society and all of that. But again, that's a big reason why PrEP isn't used. A lot of people don't know about it. And I think it's unfortunate when you go to like an urgent care and they go, hey, you got syphilis, and they go, see you later, right? And when they go like, hey, you have syphilis, do you want to have this medicine so you don't get HIV? You may have got HIV, but hey, you never get that. But yeah, so again, it's probably a whole day worth of why types of PrEP we use.
Question about just, so you said a lot of the vulnerable at-risk population is younger people, because they tend to have like this fear, or they are a part of like the at-risk group. So do you think it would be reasonable to maybe talk to people at like health clinics at universities and ask them to sort of advertise and tell people to? Because I know from personal experience, like it's very easy to get tested for things at health clinics. So if people are coming in to get tested, then it would be easy enough to have that chat with.
Yeah. So a lot of health places do that, like Producing Health does PrEP. We're partnering with Florida A&M University as well as our HBCUs to provide PrEP on campus as well. When you get to young people, it's a whole another ballgame. So again, it's the thought of like recognizing the risk factors for PrEP. When you're young, you're invincible, and that's never going to happen to me, right? So that's part of it. The other part is, if you want to call it a stigma, right? But if you're young, you're potentially under your parents' insurance. And if you're under your parents' insurance, then your parents are going to get a notification that says, hey, thanks for your visit to Charlie Burns infection disease doctor on Friday. And they call you and go, hey, why did you see Charlie Burns infection disease doctor on Friday? Why is my insurance costing what's Truvada? What's Truvada? Why are you on Truvada? No, now you're out.
Yeah.
So a lot of there are projects that we're doing here at Duke. I don't know if you guys talk to come talk to you.
Yeah.
Okay. But he's another ID guy, and he does evidence and practice. He actually goes to HBCUs and teaches students there about HIV prevention and how to make a career out of HIV prevention outside of just like the traditional like prostitution type of thing, and making PrEP awareness on PrEP awareness. So there's a lot of insight into that too. But again, it's just kind of there's other issues with young people too that don't.
So you said that PrEP is prescribed at academic centers, but is that mostly at your clinic, or do you use that too also?
The answer is maybe, right? Yeah. So yes, but we have a Duke.
You can look at that.
What?
You can look at that as EHR, right?
Yeah, so there's the Duke PrEP clinic. And with the Duke PrEP clinic, we see the majority of it, which is, I don't know, if I look at it, it's fair to sound like 600 people. But there are a lot of PCPs in the Duke system that'll do it, and there's some that don't. So we have a list, on our end that we're going to keep track of who does it, so we can refer to well. So again, some patients prefer to come see us and do their PrEP care. They feel like, if you go to a dedicated PrEP clinic, it's safer, meaning that there's no judgment, right? You can walk in and tell me what you're doing, and they know nobody's gonna care. Whereas some people don't feel that same comfort with their primary care doctor. And some people love their primary care doctors. Sometimes, for those primary care doctors who aren't comfortable with PrEP, they'll send them to us first and say, okay, we spoke with the patient wants the SCOBY. Here's we've got a monitor for the SCOBY. Back to you, right? They'll take it from there.
So, how do patients find the PrEP? Is it usually from referral?
So we have ads, right? So there's websites. So there's PrEPlocator.org, PrEP.me, or maybe, I don't know, there's websites you can go to where you say, I want PrEP, and it'll show you PrEP clinics in your area. It's not perfect. We have advertisements, so if you look up Duke PrEP, the Duke PrEP clinic will come up. We used to run ads in Grindr, we don't anymore. And then referrals. So we have a lot of partnerships with LGBTQ community organizations, like Central and Triangle, Power departments, and they will talk. You know, people are coming into those groups to get HIV testing. They'll say, hey, so yes.
They usually just like once a year visit, so people are.
So that's the other part, correct? Every 3 months. Yeah, it's just more like if you're like you see your doctor once a year, or not, right? You see them every 3 months. No, right? So that's a big barrier too, is that right now the guidelines say that you have to have HIV testing every 3 months while you're on PrEP, probably for good reason, but that's one of the barriers for PrEP care.
So you have people that drive from rural areas or other areas. Yeah, I mean, it's great that they're doing that, but it's also just like accessible.
Yeah.
I mean, you have to deal with shit for gas and parking and take time off of work.
Yeah, you might say, oh, why? Why don't I just see them yearly? And I think the issue with PrEP is that if you are on PrEP, then in theory you are doing something that would put you at vulnerability to HIV. And so if we're going to acquire HIV while on PrEP, that'd be bad. Because then you're in theory you can develop resistance. You want to know it right away and be on full treatment. And so if you wait that year, you know, it might be, right? But there are some studies, there's some arguments saying that the every 3 months thing is too much, and that people on PrEP generally are not getting HIV if they're taking the medicine correctly. So why can't we say, hey, we've been doing this for a long time, we know they're reliable, take it. Why can't we say like just show once a year, right? But right now I think it's because the guidelines say every 3 months that if you're not doing that, so you get HIV from a medical legal standpoint, they sue you and then you're got no part of it.
How often do you do one of those tests actually?
I don't think I have to think about this here. So we've had people who come to the PrEP clinic and had a positive test before they started PrEP, which makes sense. And to my knowledge, we've only had one person convert while on PrEP, but we actually call it, they say, oh yeah, taking all the time, we call it pharmacist now for 6 weeks. So the people who convert on PrEP generally aren't taking it. But the studies have all shown that PrEP, if you're taking it correctly, it's
Coming back to the appointments, they have to be good adherence, you know.
you make that.
So, the people with maybe existing sickness like illness, is there any special reaction when they take PrEP? Like when they
had HIV? Like
no, maybe like ulcer, maybe like things.
Oh, very well tolerated. So, like, you mean like you already had an ulcer?
Yeah.
Oh, it doesn't interact with us. It's good.
When they like go see you, do they have to like take a certain test and do something else? Are those tests like?
Every 3 months.
Yeah. Can they like do it by themselves and then like?
No, so you guys do a formal like blood draw HIV test at the very end. And usually you have, I mean that's the basic stuff. But usually you also maybe do STI testing, but you can't do like a rapid test because they're not sensitive specific enough. You gotta kind of get a formal testing.
Do you know how the injectable works? Like what makes it long lasting, and can you make it even longer lasting?
Yeah. So right now I can't tell you pharmacologically, but Evertude is injectable. And so it's injection in the butt. So I usually tell patients like if you've had a shot of penicillin in the butt, tracks in the butt, that's what it feels like. The way you do it is you get it on day 1, you get it 30 days later, then after that it's every 2 months. And then it's more effective than oral PrEP. And I don't really know if it's actually more effective or it's more effective in the sense of you don't have to take a pill, it's more effective. And it's really well tolerated again, like you don't really need any lab monitoring at all other than your HIV test. The biggest concern with the Aperture though is one, crazy expensive. So if your insurance doesn't cover it, you know. But 2, and then it always makes you laugh, right? So insurance companies will usually say like, oh, we'll approve this when the patient fails Truvada. If I fail Truvada, mean they got HIV. Like, oh no, we don't need that. You know? But anyway, the biggest risk with Aperture over Truvada or Descovy and Truvada, scoping provider are generally out of your system within 7 days. Amplitude, once you get your injection, it's in your system for at least a year. And we don't know at what point is it no longer protective. So at some point, the drug level drops to a level where it's still detectable in your blood, but doesn't protect you from HIV. If you get HIV at that point, then you have HIV replicating in the setting of cabotegravir, which is what the generic name is for that. That's an integrase inhibitor, and so you can develop integrase inhibitor resistance. And if you develop integrase inhibitor resistance, all first-line HIV drugs are out the window for you. So that would be that. And so generally, I do Amplitude for persons who either can't tolerate the pills, if it is the only one that do, or people who I know are reliable. Those people who kind of get one just because they purpose. But you can also justify saying, hey, doing this might protect HIV, but yeah.
Is there a similar campaign for PrEP or anything like that?
Oh,
Pharmacist?
real quick.
Yeah.
Yeah, so there is. Didn't get into it. That was a little trickier though, because with PEP, you have to be within 72 hours of whatever your exposure is. And you have to be able to get like a lot of, there's like more labs you need to get before you start it. So generally if somebody's I think North Carolina, they just passed the law. But in some states you can go to the pharmacist and say, hey, I want PEP. But again, a lot of times if somebody needs PEP, send them to like urgent care or emergency room, with a 72-hour window. Taking it once you're outside that window, you're
Okay.
that's a little enough. We can talk about that too, but that's a little harder.
So you were saying how having a PET injectable in your system once it drops off to a low enough level and potentially being exposed to HIV, how risky is it that you got integrase inhibition resistance?
I couldn't give you a number, but it would keep you up.
Like, is it like quite likely? I
It's hard to say because HIV, we don't really have the data to say like 15% of these people will get resistance, but resistance does develop and can develop quickly, and it has developed studies. So will it happen? I don't know, right? I think it's kind of that question of how high is that cabotegravir level, and how long is the person, like if you had Amplitude and then you stopped taking it, you called me 3 months later and said, oh, my partner just learned they had HIV, testing you were positive, right? Your risk, I think that your risk of resistance is lower than if you had that same situation became a year later. So it's not guaranteed, but it's a real possibility. And the nice thing about PrEP is ground PrEP, if you're actually taking it, if you had an exposure like that, you're good. You don't have to do that. Slide it.
Any other questions? Thank you very much.